Okay, and here is just a sagittal section through the eyeball. Here's the back of the eye, and this is going to be the front of the eye, and we're going to start out talking about the different structures inside the eye, and also starting with the outside. There's a protective layer. Okay, part of the protective layer is going to be, I'll just outline it here in black, going all the way across. This is going to be the white of your eye, and the white of your eye is going to be part of the protective layer of the eye. Does anybody know the name for the white of the eye? Yeah, it's your sclera. Good. Oh boy, camera issues. Okay, so what I've outlined in black here, this is going to be your sclera. And sclera is part of its protective layer. That's a brand new black marker too. Okay, so your sclera is the white of the eye, and that goes all the way around here, except for this front part. And the front part is a clear covering. Okay, it's also part of the protective layer. And it's this area of the eye, and this is the area of eye where light enters the eyeball. Does anybody know what that's called, that protective layer? Here, right here, this is going to be your cornea. So your cornea is also part of the protective layer of the eye. Your cornea, and that's protective layer. Okay. Yes?
You said that's where light passes through.
Yeah, light passes through because it's a clear covering at the front of your eyeball. That's where light passes through. We'll talk more about that as time goes on. But that's going to be your cornea. So two protective areas. One's your sclera, that's the white of your eye. And the cornea is a clear protective covering. It's also part of the protective layer. Moving on to the next layer. The next layer is a vascular layer. I'm going to represent the vascular with this red color here. This vascular layer goes about halfway through, all around the inside of the eyeball. A highly vascularized structure. Okay, this vascularized structure is known as your choroid. C-H-O-R-O-I-D, and that's a vascular layer. Okay, so your sclera and your cornea are your protective layers. Coming inside the eyeball, you have your next layer, which is a vascular layer. And as that vascular layer proceeds forward, it starts to thicken, and that thickening really turns into a muscle. And then here is the muscle. So it's just a thickening of the choroid that turns into a muscle. It's also part of the vascular layer. And the name of this muscle is the ciliary body. Okay, so as that choroid progresses forward toward the front of the eyeball, it starts to thicken, and that thickening becomes a muscle. It's known as the ciliary body. And the ciliary body is also part of the vascular layer. coming off the ciliary body, you have this part of the eye that gives your eye color. So this individual is going to have green eyes. Anybody have green eyes? Okay, they're the most rare. I don't know if you know that or not. But this is going to be the part of the eye that gives the eye color. Does anybody know what that's called? Iris, yeah. So this is your iris. Okay, moving on. That's the vascular layer. On the underneath the vascular layer is going to be another layer that's called the photoreceptive layer. And that's going to reside right here on top of this choroid. So these are all the photoreceptor cells. Okay, collectively, this photoreceptive layer, these cells are all coming together and they're known as the retina. So all the axons from these cells come together and they exit out the back of the eyeball. Okay. So this is going to be your retina, and your retina is going to be a photoreceptive layer. So the retina itself is composed of two different cell types. Does anyone know the cell types for the retina that make up the photoreceptive layer? Rods and cones. Perfect. Okay. So rods are going to be 20 times more prevalent than cones. Okay. And do rods function best in bright light or dim light? Does anyone know? Dim. Okay. Rods are going to be predominantly good for your peripheral vision. Okay, your rods detect really well motion in general. So they function fine in dim light. Okay, they're good for your peripheral vision. We're going to learn how to test peripheral vision today. And they're good for detecting motion, any kind of movements. So something in the periphery moves, you're aware of it because your rods can see it. Okay, a whole lot of rods. And then you also have cones. Okay, another cell type in the photoreceptive layer. And cones are really good for central vision, so seeing things in the middle. They function best in bright light. And they're great for seeing things in fine detail. Okay, so when you have something out here that's moving, you really can't see it clearly, right? You don't see a lot of detail, you see the motion. But if you have something right in front of you that you're trying to read, that's when you're going to use your cones. Okay, so it's good for fine detail. Bless you. I'm sorry, can you say that again?
The 20x.
Oh, rods are 20 times more prevalent than cones. Okay, so there's a whole lot more rods than there are cones. Okay, any other questions? Okay. Other things we need to consider are going to be going to have here, so this is going to be the space in between your irises is known as your pupil. That's that black part of your eye. Okay, and just located behind your pupil is going to be your lens. The lens of the eye is actually attached to the ciliary body with something called suspensory ligaments. So I'll just draw them in here like this. Okay, so your lens is attached to your ciliary body through something known as suspensory ligaments. Very clearly. Okay, your suspensory ligaments. Nothing more than ligaments that attach to the lens of your eye to your ciliary body. And like I said, light is going to come in here through the cornea protective layer, going to enter in through the pupil, and the lens is going to help focus that light to a specific part of your retina. And that specific part of your retina is known as your macula. I'm just going to represent the macula here as part of this retinal layer, and the macula is an area that has a high level of cones. So it's going to be really good for central vision. Where's color is that? Blue. Okay. So this is going to be your macula. Okay, so as light enters in through the pupil, the lens of the eye is going to help focus that light specifically on the macula, and in a very special part of the macula, this little dimple right here is known as the fovea, and the fovea is the highest concentration of cones in the retina. Okay. So this is going to be the sweet spot for central vision, right here. Okay, it's going to be on your fovea. Questions? Yeah?
Is there a macula on the bottom side too, or is there only one in the eye?
It's just one specific spot. Yeah, that's just an area, it's a region where that lens is just going to focus that light specifically in the area of the fovea. Okay. Any other questions? Okay, we'll look at that in a little bit more detail later. Okay, like I said, other important things. So you know that all these are axons coming from the photoreceptive layer or the retina that are exiting out the back of the eyeball, and all of these axons coming together form your optic nerve, or cranial nerve number 2. Yeah.
Sorry, did you draw more axons coming from your spot, or are those all?
They're all those. Yeah,
Okay.
all these cells have axons coming out of them, and I just kind of thickened it a little bit. That's all. They're all the same thing. They're all axons coming from the retina, from the photoreceptor cells in the retina. Okay, and all those cells exit the back of the eyeball through a special space, and I'll go ahead and put that in. Make it purple. Oh no, orange. All the space back here where the optic nerve, or the second cranial nerve, exits, it's called your optic disc. Okay, so I sort of drawn a circle. So this just represents this hole in the back of your eyeball. It's known as your optic disc. So all this space where that second cranial nerve comes out in the back of the eyeball. You should also be aware of the fact that the space inside the eyeball isn't hollow. It's filled with a fluid, and that fluid, it's actually a gelatinous fluid. It's called vitreous humor. So I'll just represent that as little dots here. So everything from the lens of the eye all the way back through the optic disc is filled with a gelatinous matrix that's called vitreous humor. So here, vitreous humor. Vitreous humor is nothing more than the gelatinous matrix that's present inside the eyeball. And so vitreous humor is behind the lens, and between the cornea and the lens up here is another, this is more of a liquid matrix. This is called your aqueous humor. Aqueous humor is nothing more than the liquid that exists behind your cornea and in front of your lens. Questions about the structures of the eye? Any questions? Okay. So talk about some problems you might see, or you will definitely see in your clinical future. There are two big ones, really. Cataracts. Has anybody heard of cataracts? Yeah? Does anybody know what causes them? So it's actually a crystalline buildup inside the lens of the eye. And people are going to be, so their vision starts to change rapidly once you start to develop cataracts. The cure for cataracts is actually pretty simple. They do it's a surgery. It's an outpatient surgery. They go in and they pull out the cloudy lens, and then they just replace it with an artificial lens. Okay, so that's just a simple thing. Usually they do one eye at a time, and then the other eye is done a couple weeks later, so you get a chance to adjust. Okay, so that's cataracts. Patients are going to report a clouding of vision. So when they're trying to see, everything's darker because this is all cloudy and the light can't pass through the lens. So it's really hard for them to see at night. You might also complain about car lights at night being glaring, very glaring. And they really can't see very well in dim light. Okay, it's like they're always wearing sunglasses. Okay. Questions about cataracts? Yes?
What kinds of things would predispose you to have cataracts?
So sometimes cataracts are genetic. I don't know of anything, I'm a Dr. Blair, if you know of anything, I don't know anything that predisposes you, but some people are actually genetically predisposed to having cataracts at an early age. That's the only thing I know. My husband had them at 50, at the age of 50. Had to have, nobody could figure out what was going on. And all of a sudden, it's like, oh, you have cataracts, even though you're so young. So that's all I know about cataracts. Okay, another problem that you may have heard of previously is called, have you ever heard of macular degeneration? Yeah, okay. Macular degeneration is going to be a degeneration in this area of the macula where you have a high concentration of cones. Now, if somebody has macular degeneration, Do you think they're having difficulty seeing in the middle or on the outsides, based on what you know? In the middle, because this is where all the cones are. This is good for central vision. So they lose that central vision. Okay, my father has macular degeneration. It's actually, they give him shots once a month to help deter the macular from continual degeneration. Actually helps some individuals really, really well. It's helping my father. But he had no idea that he had a problem. It's only in one eye, because when they covered one eye, the other eye, there's a big hole in the middle of his vision. Couldn't see anything in the middle. So it was completely black, but then he could see everything around the outside. So, kind of cool. Okay, those are probably the two basic ones that you'll come across in the clinic that are really common. Okay, yes, Alicia?
Is it black in the middle, or is it just like fuzzy?
Well, with him, it's completely black. And as you advance through macular degeneration, it's more of a, you can't see anything in your central state, in the central portion of your vision. So, for example, if you have a patient with macular degeneration that's involved both eyes, it's probably best to walk to the side of them, and they'll follow you by your motion, but they can't see anything that's clearly defined in the middle because they're losing their macula. And it is a degenerative process. It happens over time.
So do they just start to like look at things in the sides?
They see things more clearly on the sides. Yeah. So if they're like looking straight ahead, but their vision is composed of things on the outside because they're using their rods to see. Anything else? Did you have something?
Risk factors for cataracts and age, genetics, diabetes, high blood pressure, smoking, and obesity. So some things anyway associated.
All the big ones.
All the big ones, yeah.
Yeah, pretty much. Any other questions? Thank you for that. Any other questions about macular degeneration or cataracts? Those are the big ones that you're going to see in the clinic, or at least in somebody's chart. Okay, moving on. What I'm going to do now is this. I'm going to take this picture, and the next picture, what you're going to see is just this top part. Okay, so we're blowing up this region right in here. Okay, all this other stuff is still there, but we're not going to see it on the picture. This is going to be control of the lens and the pupil. What cranial nerve controls the lens? Lens accommodation and pupillary constriction? Yes, you got it. All right. Okay, quick review. This layer here is going to be your cornea's protective layer. Part of your vascular layer. It's actually a muscle. Going to come next. This is going to be your ciliary body. Coming off the ciliary body, we just saw this person with green eyes is going to be your iris. So here's your iris. Nothing more than what we've just drawn. I think my lens was orange, so I'll keep it more like a pale orange. So, and then the lens of the eye is going to sit right back here. Okay, and attaching the lens of the eye to the ciliary body is going to be your suspensory ligaments. Okay, so nothing more than a more detailed view of what we just drew. I'm going to add in a few important pieces here. I'm going to add in some muscles. Okay, the very tip of the iris, there's going to be a muscle that I'm just drawing here in cross section. Okay, so realize this muscle would go all the way around the pupil, so it would be fully encircled right here. Okay, so that pupil is going to be the space between the iris. Okay, the muscle that is at the very tip of the iris. Where's my red? There. Okay, this is a muscle. This is known as your sphincter, S-P-H-I-N-C-T-E-R, pupillae. Okay, sphincter pupillae is nothing more than a muscle that encircles the entire pupil, and it has one job in life. If it contracts, is it going to constrict the pupil or dilate it, just based on its position? Yeah, so it's involved in pupillary constriction. Okay, and that's your sphincter pupillae. And then there's one more muscle. This muscle is going to exist here at the bottom, or the inside most piece of the iris bilaterally. Okay, and this muscle, if this muscle constricts, do you think it's gonna, what do you think that is going to happen to the size of the pupil? Is it going to get bigger or smaller if this muscle constricts or contracts? This muscle, if this muscle contracts, the one that I just drew in, what happens to the space? It dilates, yeah. So this is known as your dilator pupillae. Okay, your dilator pupillae is responsible for pupillary dilation. Does anybody remember the name of the cranial nerve nuclei that's responsible for pupillary constriction and lens accommodation? Edinger-Westphal, yes. So cranial nerve number 3 uses the Edinger-Westphal nucleus. Okay. And the Edinger-Westphal nucleus is responsible for innervation of the sphincter pupillae, causing pupillary constriction, as well as the ciliary body, causing lens accommodation. There's a video at the end that will talk a little bit more about lens accommodation, but essentially, when if the ciliary body contracts, that means it's going to squeeze together, and it's going to change the shape of the lens by flattening it out, okay, because the suspensory ligaments are attached to the lens. Okay, as it relaxes, that lens is going to start to round up. Does everybody see that? So that's the lens accommodation, is the changing of the shape of the lens to help focus light coming back directly onto the area of the fovea in the macula. And again, there's a video at the end that I can show, helps to clarify that. Okay, now these are under parasympathetic control. Okay, the dilator pupillae, should be E there, is actually under sympathetic control. Okay, but this is parasympathetic control. So with parasympathetic, you think rest and digest, right? You guys have had this in physiology?
No, not yet.
Not yet? Oh, okay. Well, preview. Parasympathetic, rest and digest. And sympathetic, you're being chased by the tiger. Right? So your nervous system goes, whoop, upscale. Okay? And if you're being chased by the tiger, you want your pupils to be dilated because you want as much light coming in as possible so you don't trip over anything. Easy way to remember it. Okay? So if somebody's sympathetic nervous system is flaring up, they're going to have great big old dilated pupils. And another thing I can tell you is if somebody's on opioids, like large amounts of opioids, which is a big problem these days, their pupils are going to be super constricted. Yep. So if you're working with somebody who's on having pain management and they're taking a lot of opioids and you see their pupils are this big around, I don't think they need any more. I think they're okay. Okay, they'll try, but just be aware of that when you can see it in the clinic. Very obvious. Go ahead, Dr. Blair.
Opioids are the only drug of abuse that produce pupillary constriction.
Okay.
And every other drug of abuse produces pupillary dilation. So it's like a hallmark.
Yes. It's very distinct. In a very bright, lit room, you're going to see teeny tiny little pupils. And that person's well medicated. Okay. Any questions about this? So sphincter pupillae and ciliary body. Sphincter pupillae is responsible for pupillary constriction. Ciliary body is responsible for the lens accommodation. Okay, just because it's contact. Yes, Alex.
So when some people have their pupil blown, are any of those muscles being affected since you can't really constrict anymore with your sphincter?
Okay, when you say pupil blown, you mean it's that person, their pupil doesn't constrict at all. Okay, that's a problem that we're going to talk about at the end of today's talk. Good lead-in. We'll get there. Perfect. Okay. Yeah. Usually, a blown pupil is a sign of a cranial nerve problem. Cranial nerve number 3. Okay. Any other questions? Good. Okay. Let's move on to visual fields. I can say I have been doing this lecture since I've been here, and I know that this part's important to understand the rest. Okay, so you just gotta see if you get it. Okay, just try and follow me along right now. And so this is going to be the transverse section through an eyeball. Okay, so here's the right eye. Okay, and here's the left eye. So that's the pupil of the right eye and the pupil of the left eye. Okay, and this is my rendition of a nose in the middle. All right. So if something is closest to the nose, it's considered nasal. Right? Closest to the nose is nasal. And if something's closest to the outside or closest to the temple, it's considered temporal. Okay, so what I'm going to do now is draw the visual fields. And on the right, I like to draw the visual fields as red and blue. On the right, this is your total visual field that I'm going to draw right up here. Okay, your total visual field represents what you see with both eyes. Okay, no eyes are covered. You're looking straight ahead in what you see. So on the right side, I'm going to have my visual field for the right is going to be red. Red for right. Red, R for red. And on the left side, the visual field is going to be all blue. And I'm doing this because it's going to be helpful to follow it back later on. Okay, So everybody see? So what I've created here is a situation where if I look straight ahead from my nose all the way out to the right side, all I see is red. And on the left side, from my nose all the way to the left, all I see is blue. So everybody see that? So that's my total visual field. Let's start with the right eye, the right visual field. You got to trust me on this one. Just try, follow along, okay? My right visual field, to do that, if I take my left hand and I cover my left eye, okay, how far over to the left can you see with your right eye? Look straight ahead. How far over to the left can you see? Can you see all the way to the far left? No. So what I'm going to represent, but can I see everything on the right side? Yeah. So I'm going to represent, this line is what I see with my right eye. So I'm going to say I see everything over here on the right side. Okay. But on the left side, I see about half, right? I can't see all the way to the very end. I can see about half of that left side. Does everybody agree with that? See what's happening? And the same thing with the left eye. Okay, so if I cover my right eye, I do the same experiment, I can see all the way over here on the left, but I can only see about half of the right side. Everybody got that? So I'm going to draw, for my left eye, my visual field represents all of that side. I can see it all if I cover my right eye, but I can only see about half of my right visual field. Everybody got it? So, when I think about nasal versus retina, when I talk about visual fields, my nasal visual field is this area here that's in the middle or closest to my nose, right? But my temporal visual field is going to be this area over here on the far outside. Okay, so I have nasal visual fields, and then I have temporal visual fields here. Okay, so in order to figure out the visual fields for both eyes, what I'd like to do is trace it back. So if I look at the nasal visual field here for my right eye, and I trace it all the way back to my eyeball, it projects to my right eye's temporal retina, or the part of the retina that's closest to the temple. Does everybody see that?
Can you say it one more time?
Absolutely. So I'm just looking at the right eye, what my right eye can see. The nasal visual field here for my right eye projects to my temporal retina. Okay, so that's where I'm seeing that at. So my temporal retina sees my nasal visual field for my right eye. And for my right eye, the temporal visual field from my right eye projects to my nasal retina. Does everybody see that? And then these retinas I showed previously, they just the axons of the neurons just connect. They go right on down. And that forms the second cranial nerve. Okay, everybody got it? Questions on that? All right, let's look at the left eye. So when I look at the left eye, it's going to be the nasal visual field of the left eye projects over here to the temporal retina. And that temporal visual field for the left eye projects to my nasal retina. questions? If we get lost, we can come back to this. This is the important part. If you can get this down, I think the rest makes a lot more sense. Okay? Well, that's going to be your visual fields. Now let's look at visual tracks. Okay, I will label this. This is going to be the right side. This is going to be the left side. Again, here's my nose. Here's my eyeballs. These are ears. So you're essentially looking straight down. So it's a transverse section right through the eyeball and all the way back. Okay, and this back here is going to be a representation of the occipital lobe. So essentially, vision comes in through your eyeballs, travels back the second cranial nerve, and ends up in its process back in your occipital lobe. We talked about that way back when. Okay, so I'm going to choose to represent this as the occipital lobe. Okay, and the occipital lobe representation, it has a superior portion, so I'm going to put up here is superior, and down here is inferior. And this is nothing that more than the top and the bottom of the occipital lobe proper. Okay, two different hemispheres, one on the right and one on the left. Questions about the picture, where we are? Okay, let's go back and look at, what I'm going to draw in is my total visual field. And again, the right's going to be red. Entire right visual field is going to be in red. And then the entire left visual field is going to be here in blue. And all we're going to do is trace it back. Starting with my right eye, what my right eye sees, the nasal visual field of my right eye projects to the temporal retina. Nothing more than what we just drew. Okay. Where's my red? Okay. The temporal visual field of the right eye projects to my nasal retina. And in the same way, with my left eye, the nasal visual field projects to my left temporal retina. And my temporal visual field projects to the nasal retina of my left eye. Okay, same as what we just drew, right? No changes? We're good? Okay, let's take a 10-minute break.